Good afternoon, everyone. We are back, ready to start the presentation. Again, my name is Janet Bruno-Gaston. I'm one of the newest providers here at the Center of Reproductive Medicine, and I have the pleasure this afternoon of speaking to you about polycystic ovary syndrome. I'm going to start giving a brief introduction about myself. We'll go into the evaluation of polycystic ovary syndrome, some of the common management options, and things to consider long-term, whether you are planning a family or not, and then provide some opportunity for you guys to ask questions. And I have some questions as well. We'll get into a little poll. So first and foremost, a little bit about me. If you've had time to read my bio, I am a native of South Florida. I grew up in Miami, went to medical school at Morehouse School of Medicine in Atlanta before joining University of Southern California at LA County Hospital, and then came back here in Texas at Baylor College of Medicine. So clearly I don't believe in winter, kind of truck along the South from the East to the West Coast here. A little bit about my clinical interests. So I did my thesis work in polycystic ovary syndrome, really looking at developmental programming and this concept of how PCOS can change the intrauterine environment and what impact that has on offspring for multiple generations to come. I also looked at non-invasive markers of oocyte and embryo development, ways in which we clinician scientists can kind of determine whether or not the oocyte and the embryo are competent and prioritize them for selection with treatment. I also have a strong interest in fertility preservation and advocating for women and men to really take ownership and feel empowered as it in regards to family planning decisions. I am also active in patient education. I chaired numerous committees and projects trying to improve communication between patient and providers. I'd like to enhance the role of technology with artificial intelligence being very helpful in kind of going through these very dense counseling discussions, and so trying to find ways to incorporate that in the clinical experience will be something that I work on here as well. I also want to improve access to care, especially as it pertains to reproduction. I think we, as a nation, should strive to improve access to care, and whether that be from education, awareness, but certainly coverage and inclusion, and viewing fertility as important as we do other conditions in this country. And then also I'd like to address disparities in outcomes. So certainly we see differences amongst ethnic groups and different races and ages, and trying to figure out ways in which we can improve outcomes and close the disparity gaps amongst those groups. And then a little bit about my personal interests. So I am an island girl at heart. My mom is from the Bahamas, so I spent a lot of time on the island and a lot of time in the water. That picture was actually taken here in Galveston in the midst of COVID. Just really got tired of being in the house, and they offered, chartered boat rides there. And so great. I love being out on the water. I love cooking. This is kind of one of our classic Bahamian dishes. This is called conch fritters, very similar to like a crab cake, but with a Bahamian delicacy, which is conch. So if you're ever in the Bahamas or even in South Florida, you definitely want to give those a try. I also love music. I actually went to a school of the arts and majored in vocal and minored in dance. So that has been something that I've always been passionate about, but I did realize I was better at science. So that's a little bit about me. Now on to polycystic ovary syndrome. So this is a very complex disorder, and the way in which it presents, what it looks like, varies considerably from one patient to another. But ultimately, the biggest issue is the abnormal production of steroid hormones in the ovaries. That changes the hormonal environment in which the follicles are developing in and leads to a slew of clinical implications for patients that affect them in both reproductive and non-reproductive organs. It is extremely common. It affects about 10 to 15% of reproductive age women. And even when you look worldwide, depending on the criteria you use, there are some studies to suggest even higher rates of up to 20%. The hardest part is really diagnosis. And, when I'm talking to patients, I think it's important to know that PCOS is a diagnosis of exclusion. And what that means is there are other diseases that can masquerade like PCOS. And it is very important for us as clinicians to exclude those because the management and treatment is very different than it is for PCOS. And so after you have excluded other conditions that could look like PCOS, like thyroid disease, prolactinoma, which are pituitary tumors in the brain, then you start to really hone in on PCOS and defining those criteria. So if you have concerns and you're curious whether or not I have PCOS, as a clinician, these are the things that we are looking for. We here in the United States use the modified Rotterdam criteria, and it has 3 characteristics, of which 2 qualify you for PCOS. Ovulatory dysfunction is one of the most common features, and that is evidence that you're either having irregular cycles or cycles that are unpredictable in terms of the bleeding profile, or sometimes patients have regular cycles, but that does not mean they are in fact ovulating. And we'll get into a little bit more of that. The other criteria is something called polycystic appearing ovaries, which is a classic appearance on ultrasound of these immature follicles that form clusters around the ovaries. And the last criteria is excess androgens. So let's talk a little bit more about ovulatory dysfunction. So I won't go in depth on basic science, but I do think it's important for some of these big concepts for you to understand, not only from a diagnosis standpoint, but this is important in regards to treatment. So unlike men who continue to produce sperm throughout their lifetime, women are born with a finite pool of eggs, and slowly throughout the course of their life, they decline in quality and they also decline in quantity. Every month at the beginning of a cycle, a group of follicles is recruited to grow with hope that maybe one will reach a dominant follicle and ovulate. In women with PCOS, the abnormal hormonal environment prevents their maturation. So you have all of these follicles that are kind of stuck in a very immature state, and they're not able to actually develop into a mature follicle in which they can ovulate. Clinically, that may come across as patients not having periods for months and then having irregular or sporadic bleeding, because that bleeding is not truly from ovulation, but ultimately as the lining gets thick enough, it will begin to slough off, and it will do so in an unpredictable manner. So in regards to the polycystic ovaries, well, those immature follicles that are not maturing continue to form these rims around the ovary, and that is why we see this very classic polycystic ovary on ultrasound of women who come in with PCOS. And the last aspect that is also very important is excess androgens. Androgens are steroid hormones that are responsible for the development and maintenance of male characteristics. Women have male hormones, and they are important in the development of eggs, but all in the right proportion. But androgens kind of act from many different levels to result in some of the clinical implications that we see with PCOS. One way in which they do that is place women at risk for insulin resistance. So excess androgens requires more insulin for the control of your blood sugar. Excess insulin acts on the ovaries to drive more androgen production. And so this becomes this perpetual cycle of elevated male hormones, increasing levels of insulin that put women at PCOS at risk for not only disruption in ovulatory function, but also in diabetes. So clinically, these patients look very different, and it's likely because the cause is very different. But we know that there is some hereditary pattern because there are studies that show that daughters of PCOS mothers have almost a 5-fold increased risk of diagnosis during their lifetime. And there have been studies to identify genes associated with PCOS, but we really think that only accounts for about 10% of the heritability that we're seeing. So there must be other factors that are involved in this increased incidence of PCOS. And so we think the origin is likely multifactorial. So that has to do with the evaluation, how we figure out what's going on, who identifies with PCOS, and what are kind of the basic science things that are disrupting normal ovulatory processes. But how do we manage them? So it's important because, one, this can become the most common cause of anovulatory fertility. So these women are struggling to get pregnant, and usually the rate limiting step is getting them to ovulate. But even more important is the other health conditions that are associated with PCOS, and that is diabetes, metabolic syndrome. They're at higher risk for cardiovascular disease, as well as increased rates of depression, anxiety, and most recently, sleep disturbances. The management of PCOS largely depends on whether or not you are actively trying to plan a family, because that will determine where we want to manage the symptoms. But it's also important for us to see the patient as someone that is not just trying to get pregnant, but an individual that even after family planning, PCOS is still present and we still need to pay attention to it. So I always tell patients that once you have finished completing your family, please, continue to follow up with your gynecologist because this PCOS does create risk factors for you in the future. And I like to look at the impact of PCOS and how we manage it based on systems. And so the first and most common that we are actually caring for is the reproductive system. So let's start there. So in regards to reproductive system, having periods is important. Having a period is like a vital sign. It's like your blood pressure. It's like your pulse. It tells us about the function of your reproductive system. And so without contraception, hormonal therapy, or an indication why you aren't ovulating and having regular periods, you need to be investigated if you are not. And so for patients that are deciding to plan their family, one of the initial treatments that we start with is ovulation induction. For patients that are not trying to plan a family, the most important thing is endometrial protection. So even if you are not trying to get pregnant, if you are not ovulating, that can put you at risk for the development of precancerous lesions in your uterus. And so most commonly, we will start patients on birth control pills or a hormonal medication called Provera to help protect the lining of your uterus when you are not having ovulatory cycles. But for women who are trying to build their family, the rate limiting step for us is getting you to ovulate. And there are two basic treatment options, and we'll start with ovulation induction. So ovulation induction is the process of giving medication to stimulate the growth, maturation, and ultimate release of a mature egg from the follicle. The two most common oral agents that we use for ovulation induction are letrozole and Clomid. Letrozole has now replaced Clomid as the first-line agent for ovulation induction. And that came from studies that have shown that it's more effective in inducing ovulation, and it is also associated with a live birth rate. So those studies showed an ovulation rate of 61.7% versus 48.3% on Clomid. So now that we know that Clomid is more effective, letrozole is more effective, we now start with letrozole as our first agent in women who are seeking fertility treatment with ovulation induction agents. Other treatment options for women who do not respond to ovulation induction include controlled ovarian hyperstimulation, or commonly known as IVF. Essentially, the goal is the same: to recruit and mature follicles with mature eggs. However, prior to ovulation, those eggs are retrieved, fertilized in the lab. This involves daily injectable medications, and we look for multifollicular recruitment. The biggest risk associated with controlled ovarian hyperstimulation is ovarian hyperstimulation syndrome. Essentially, the vessels in the ovary and in other parts of the body become very leaky, and it can lead to fluid accumulation around the ovaries, in the abdomen, around the lungs, and sometimes around the heart. Things that we do to minimize the risk is manage the cycle by looking at the ultrasound and labs and adjusting medications, and also the type of medications that we use to reduce the risk. Ovarian hyperstimulation syndrome complicates about 5 to 10% of IVF cycles, and that number has gotten less and less as we get better at predicting outcomes with IVF based on ultrasound and labs, and the medications that we use during the IVF cycle. But risk factors for ovarian hyperstimulation syndrome include PCOS. So outside of reproduction, why should I be concerned about PCOS? Well, it has a lot of metabolic issues. So a part of our evaluation for PCOS often includes looking for lipid disorders, glucose tolerance testing, because although you may not have diabetes, there may be early signs that we can see insulin resistance, in which your body is requiring higher and higher amounts of insulin to maintain a normal blood glucose. Looking at your weight with a body mass index and also waist circumference are also risk factors for cardiovascular disease in the future, and we try to include that in your evaluation as well. The incidence of diabetes in PCOS women under 30 is 11.9%, and that's compared to 1.4% in the control population. So there is a much higher incidence of glucose intolerance in PCOS patients. About 70% have some abnormality on their lipid profile. So again, that's why we kind of screen for lipids. And all of these factors combined actually put women at risk for cardiovascular disease, and about 33% have metabolic syndrome, which is a group of symptoms that have been associated with heart disease in the future. An important factor in driving some of the issues with PCOS as well is obesity. It is strongly associated with PCOS. However, about 20 to 25% of patients with PCOS are not obese and are considered lean PCOS patients. There's about a 5% increase in a difference in weight loss that can improve reproductive outcomes. So just a 5% change in your weight could help with the ovulation induction agents. They can improve your outcomes with the treatments with IVF. So we do encourage lifestyle modifications even during your evaluation and treatment, because that can have direct effect on your outcomes. And some of the agents that we found to be helpful is metformin. You probably heard of metformin. It's most commonly synonymous with diabetes, but in fact, insulin is a sensitizing agent. That means it helps your body respond better to insulin. And so by responding better to insulin, you need less insulin to change your blood glucose levels. Keeping your insulin level down helps keep your male hormone levels down, helps improve the body's response to hormones released by the brain. And so adding metformin, even with an ovulation induction agent, could actually improve your ovulation rates. There have also been studies to show that metformin could help with weight loss. And by decreasing your insulin levels, insulin is a steroid. And so steroids tend to store fat. So having lower insulin levels, metformin has been associated with weight loss. It is currently not being used this way, but there are some studies that suggest that metformin could help prevent glucose intolerance in the future. And so that's something that we often place women on with PCOS while they're trying to get pregnant, but it may be something to consider long term after you have completed planning your family as well. And the last system that I want to talk about is mental health. And I think this has been missing from the discussion for many years, but we now know that PCO women actually have higher rates of clinical depression, anxiety, and higher rates of eating disorders. And so this is a vulnerable population in which we need to screen for depression and anxiety, because not only would that have an impact on your quality of life, but certainly that could have an impact during pregnancy and even into the postpartum period. So I just want to mention that as something that it's not just something clinically that we see. There are studies to suggest that there are changes in hormonal signaling in the brain that could also contribute to higher rates of depression and anxiety in this patient population. So certainly, we've talked a lot about what PCOS is, what it looks like, how to manage PCOS, and what are things to consider while you're planning a family and while you are not planning a family, but just wanting to stay ahead of your health and make sure that you're up to date on all the screening exams and looking for things that PCOS could affect in the future. I want to open the forum up to give you guys some time to ask questions. And I also have a poll of questions as well if you don't have any, just for discussion points. So I'm happy to take any questions that you have at this time regarding PCOS. Anything in the chat? Am I able to see it here?
So someone just commented. So they're commenting on it. It says, "What are my chances of becoming pregnant naturally if I'm managing my PCOS?"
So I saw a comment in the chat about what your chances are of becoming pregnant naturally if you are managing PCOS. That's a good question. And certainly there is room to promote natural fertility. The question is whether or not you're ovulating. And that can be hard to tell for someone with PCOS. Even if you're having regular scheduled bleeds, that does not necessarily mean that you're ovulating. So if you are ovulating and have had a complete evaluation to look for structural causes, male factor causes, your chance of conception would be very similar to a healthy young reproductive age couple of about 18 to 20% per cycle. But the missing information with the PCOS patient is whether or not that actual cycle is truly an attempt if you're not ovulating. Ovulation predictor kits are commonly used. However, in PCOS women, because you have abnormal hormonal levels, it's very common that you get false positive results, or there'll be several days where you see a surge. And so it becomes very hard to assess when your fertility window lies. So I would certainly recommend being seen by a fertility specialist if you know you have PCOS and you're under the age of 35 and you wanted to try. I would say 6 months, and then after that, with nothing, certainly follow up with a fertility specialist. If you're over the age of 35, I would recommend coming in sooner to see a fertility specialist.
Can PCOS go away on its own?
Another question through this chat was, can PCOS go away on its own? We don't know if PCOS ever goes away, but we certainly know that you can manage symptoms. Weight loss, diet, lifestyle changes have had a significant impact in decreasing risk of the metabolic complications like diabetes, metabolic syndrome, and cardiovascular disease. In terms of the reproductive effects, if you are able to get to a point where you are ovulatory and you have what I like to consider endometrial protection, then essentially you would always be in a state of management. But it's very much like someone who has hypertension. They may have been on medication. They were able through diet and lifestyle modifications to get off of the medication, but they still have hypertension. And it's something that you have to constantly manage and constantly be under surveillance for.
So another question is, what if all hormone androgen levels and lipids labs are normalized but still experiencing PCOS symptoms?
Yeah, so another question came in about experiencing PCOS symptoms in the presence of normal androgen labs, normal lipids, and that is not uncommon. And so the difficulty, as you saw, was with the diagnosis, in which you can still have just 2 of those criteria are necessary to rule in for PCOS, as long as we have excluded other causes that could look like PCOS. So yes, it is possible for you to have PCOS even in the setting of normal androgen levels.
And then you may have hit on this, but if I have PCOS, do I have it forever?
Another question came in about PCOS and how definitive that diagnosis is. Once you have it, do you have it forever? The short answer would be yes. Yes, this is something that is going to require surveillance in the future, and it is something that can be managed. And so I don't want the stigma of saying I have PCOS and more of I'm managing my PCOS, because I know several women who have done a lot of work in terms of lifestyle and dietary modifications, who are now ovulatory, not actively trying to conceive, but are essentially healthy and their symptoms are under control.
Okay, that was our last question.
Okay. So I saw that was our last question. I had a game here. If you guys want to play, I have just some questions about PCOS, some common questions that I get from patients, and things that come up during their treatment. If you can use your phone, and you can type in our game pin and you can participate with us. And we have a small gift for the winner of the poll this afternoon, and really appreciate you guys for joining us and adding to this discussion about PCOS. So let me know if you can enter that game pin. You can go to kahoot.com and you can remain anonymous, and you can just type any name or tagline that you want. All right, we've got players. I'm going to give one more minute to allow people to join, and then we're going to get started. Happy hump day, everybody. I hope everyone's having a great week. All right, I think we have a small quorum here. It may still allow you to join, but we're going to go and get started with what we have. All right, here we go. What percentage of reproductive age women have polycystic ovary syndrome? And it'll give you a countdown there. We're at 5 seconds. And you can go ahead and submit your answer. All right, so it's actually more common. So you'll see reports anywhere from 5 to 20%. Here in the United States, we usually settle in at about 10 to 15%. So this is extremely common, and as an infertility specialist, probably one of the most common reproductive endocrine disorders that we see daily. All right, so we're going to go on to the next question. And this is a true or false. So only PCOS women with obesity are at increased risk of metabolic disturbances like diabetes and cardiovascular disease. And we're at 5 seconds now. All right. Perfect, perfect. You guys are absolutely right. You do not have to be obese to be at increased risk for those disturbances. So remember, we talked about the role of androgens and how they influence insulin levels. About 20 to 25% of lean PCOS women have underlying glucose intolerance and disturbances, and they too can be at risk for diabetes and cardiovascular disease. Good job. All right, AJ, you are leading the pack. Next question. What is a health risk associated with PCOS? Is it anovulatory infertility, diabetes, obesity, or all of the above? All right. Yep, all of the above. All of those are health risks that are associated with PCOS. Okay. I think we have one more question here. So what kind of complications during pregnancy are associated with PCOS? This is a very common question. Is it hypertensive disorders of pregnancy, gestational diabetes, cesarean section, or all of the above? I see one answer in. Go, 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 click, click, click. All right, so all of the above actually. So women with PCOS are at risk for hypertensive disorders of pregnancy. So that means preeclampsia, gestational hypertension, Very serious conditions in pregnancy that often times have to be managed with medication or lead to a preterm delivery. They're also at risk for gestational diabetes in a similar fashion than as they are in future in their life. And it also shows that women with PCOS have higher rates of cesarean section. And a lot of that is probably due to those complications that may require an early delivery or an emergent delivery because of the complications. So all of the above. All right. So this is our podium, and our third place is Anonymous. In second place is AJ, and in first place is Leah. So Leah, feel free to, does it allow them to text through the chat, or we'd like to share a gift card with you?
If they can message the quorum.
Facebook?
Yeah.
If you could message the Quorum Facebook, Leah, we would love to send a gift card for you. But thank you everyone for participating in the poll today, for tuning into the lecture, and hopefully this is one of many, and would love to have your feedback. You feel free to post on Facebook if there are other topics that you would like to hear about, or if you have more questions about PCOS, I'm happy to dive deeper into that. But I look forward to meeting you all. I look forward to joining this family, and hopefully we'll see each other again. Thank you so much. You guys have a great rest of the week.